Hi, my name is Tara. I am with the Ben and May T. Fish College of Pharmacy presenting my patient today. So my patient is a 69-year-old white female who's admitted on 6/11/2016. Chief complaints as follows. So she AB presents to the emergency department after experiencing multiple falls. She originally came in after experiencing multiple falls, but was brought into the emergency department by EMS due to falling once again. This time AB states that she felt lightheaded, fever of 102 Fahrenheit, dehydrated, shaky, experiencing word difficulties. She was brought in with altermentation, but was able to answer a few questions, but less as it progressed. She became less talkative, and her mental status de-escalated progressively. Her past medical history includes COPD, asthma, hypertension, type 2 diabetes, hyperlipidemia, history of CVA, nasal polyposis, peripheral vascular disease, and iron deficiency anemia. She has had a skin graft twice for 30 reborns, sphenoid surgery for nasal polyposis. Both her parents have had CAD. She previously smoked tobacco but quit over 10 years ago. Immunization status is unknown. Current body weight is 153 pounds. Ideal body weight is 100 pounds. Adjusted is 121 pounds. No known drug allergies. Currently, patient is on Duoneb 0.83-0.017%. PO 1 puff QID. Albuterol 16 grams PO 2 puffs every 4 hours to 6 hours as needed for shortness of breath. Aspirin 81 milligram by mouth 1 tab daily. Atorvastatin 40 milligram by mouth 1 tablet once every night. Budesonide/formoterol 160-4.5 micrograms PO 2 puffs BID. Vitamin B12 500 micrograms PO 1 tab daily. Calcium plus D3 500-400 PO 2 tabs daily. Cetirizine HCl 10 mg PO 1 tab daily. HCTZ 25 mg PO 1 tab daily. Lisinopril 40 mg PO 1 tab daily. Montelukast 10 mg PO 1 tab once every night. Amlodipine 5 mg PO 1 tablet daily. Glipizide 10 mg PO 1 tablet BID. Guaifenesin 100 mg/5 ml PO 20 ml every 4 hours. Metformin 1000 milligrams PO 1 tablet twice a day with morning and evening meals. The medications that were considered at the hospital include Duoneb, albuterol, aspirin, atorvastatin, the Symbicort, vitamin B12, cetirizine, amlodipine, and then they additionally added ceftriaxone injection 1 gram IV once daily, the potassium phosphate injection 59 MEQ, and 500 mils of D5W. IV once over 6 hours, no faster than 10 MEQs per hour. Magnesium sulfate injection 2 grams IV once every 2 hours, or once for 2 hours, azithromycin injection 500 milligrams IV daily for 3 days. Enoxaparin injection 40 mg sub-Q once every 24 hours. Insulin glargine injection 12 units sub-Q once every night at bedtime. And sliding scale and Lispro insulin. Her vitals include the blood pressure of 109/40, heart rate is 84, temperature is 99.1 on admission. Respiratory rate is 16. The O2 stat is 98. She's experienced a 0 out of 10 on the pain scale. So 0 out of 0 to 10. No pertinent PE. Pertinent labs include a 310 glucose, which is really high. The HCT is 31, which is low. The white blood cell count is 14.1, which is high. The hemoglobin is 10, which is low. Those are all of the pertinent ones. The serum creatinine is 1.03. Her creatinine clearance is 42. Her baseline serum creatinine is typically 0.7. Her glucose at 307 on 6/11 is 318, and it escalated to 381 at 12/11. As far as microbiology, she had large numbers of white blood cell esterase and white blood cells shown in Puria. CXR showed no abnormalities. She had a head CT with mild chronic microvascular ischemic disease with a remote lacunar infarct on the left corona radiata and centrum semiovalve. The EKG shows normal sinus rhythm. As far as her problem list, so these are going in order of the most pertinent to the least important. So first, she is experiencing acute encephalopathy. As the patient presents to the emergency department, very talkative, able to answer questions such as her name, where she is at, different commands, but then she shows a decline in these capabilities. The patient begins to get quieter and could not answer any more questions. Her head CT scan was completed immediately, but was unremarkable. She had potential causes to mental status decline, including the UTI, hypercarbia, and metabolic causes. So the patient was started on ceftriaxone 1 gram IV daily. As far as planned, so what I would recommend is to order a urine culture and a hepatic function panel Currently, the patient was started on immediate ceftriaxone 1 gram IV daily, but after obtaining the cultures, adjusted antibiotic treatment as needed for the correct empiric coverage. Monitor the patient for improvement in mental status and keep close attention to the patient as they are on a decline in their mental status. Next, I would refer to the AKI. Patient presents with a CR level of 1.03, whereas her baseline is typically 0.7. This could be due to dehydration. It was recommended to hold the hydrochlorothiazide and lisinopril, but continuing the normal saline at 100 mL per hour. A BMP is ordered to continue to monitor the CR levels and ensure that they trend back down towards the baseline level. What I would recommend is to continue holding the HCTZ and lisinopril as the blood pressure is currently low anyways, and it wouldn't harm the patient at this moment. So monitor the patient's CR levels to ensure that they do trend back down to the baseline of 0.7, as well as monitoring their blood pressure, of course. Next, I would look at their diabetes, type 2 diabetes. So patient's glucose is uncontrolled. It's supposed to be 310 at admission and escalating. Patient's currently on metformin and glipizide. Previously in March, she had an A1C of 10.1. What they plan to do is order a HGB-A1C test and retest the A1C levels. So they were considering adding the patient on a sliding scale insulin due to the uncontrolled glucose levels while being on 2 oral agents. The current regimen is not adequately helping the patient's levels, and an intervention is needed at this point. I would continue with the order of the A1C test and determine if the sliding scale insulin regimen is needed to be added to those oral agents, and consider adding the patient on a basal insulin depending on the A1C test. And monitor every 6 hours to ensure that the patient's glucose levels are under control. Next, I would look at the COPD. So currently, patient's not experiencing any signs or symptoms of wheezing or in need of any breathing treatments, but she is currently on home O2 2 liters, but reports being on 3 liters previously. She's currently on Duonub 0.83-0.017% PO 1 puff Q 4 hours. Albuterol 16 grams PO 1 puff every 2 hours as needed for shortness of breath. And the budesonide formoterol 160-4.5 micrograms PO 2 puffs BID. These are continued in the hospital as well. So currently the patient's on 2 different albuterol inhalers, one being Duonub and the other is ipratropium and albuterol. So that's what Duonub is, sorry. And then the other one is the albuterol, which is the single agent. All 3 of these medications are continued in the hospital. There's no signs of COPD or shortness of breath, but an intervention is needed since we are doing dual therapy right here. So I would consider de-escalating the therapy and removing Duonub from the therapy where the patient is on Symbicort and albuterol alone for the treatment of COPD. Monitor the patient for signs and symptoms of shortness of breath upon discharge and follow the patient every 2 months and then yearly once they are under control with that de-escalated therapy. Next, I would refer to the hypertension. So the patient does have a PMH of hypertension and is currently on hydrochlorothiazide 25 mg PO 1 tablet daily and lisinopril 40 mg PO 1 tablet daily. At this point, both medications are being discontinued due to the AKI and attempting to resolve that problem first. My plan is to continue discontinuing these both medications as that is appropriate, but it is important to continue monitoring her blood pressure to keep that goal less than 120/80, as the blood pressure may rapidly increase once taken off these medications. So monitor the blood pressure every 2 hours until it's stable, and adjust the therapy as needed. Monitor the patient for any signs and symptoms of dizziness. For her past medical history of hyperlipidemia, so this patient presents with a PMH of hyperlipidemia, currently on atorvastatin 40 mg PO 1 tablet once every night. It's continuing in the hospital. At this point, consider ordering a lipid panel to ensure that atorvastatin is getting the HDL levels at a goal of 45 mg per DL or higher. As far as feeding, the patient was put on NPO due to altered mental status. Continue patient on NPO until mental status improves and can be taken off the NPO. For your VTE prophylaxis. So patients at high risk for developing VTE per the Wells algorithm and requires pharmacological prophylaxis. Patient was started on enoxaparin 40 mg sub-Q every 24 hours. Plan is to continue the patient on the enoxaparin 40 mg sub-Q every 24 hours for the prophylaxis, as this dosing is safe. Monitor for injection site redness, hemoglobin, hematocrit, platelets, or other signs and symptoms of bleeding daily. Follow up with the morning labs daily. And lastly, iron deficiency. So currently a patient has low hemoglobin at 10 and hematocrit at 31. No medications are currently being added to this problem, and an intervention is needed. Consider adding first-line treatment for iron deficiency of ferrous sulfate to 20 mg per 5 ml PO once daily. Monitor the hemoglobin, hematocrit, ferritin, red blood cells every 6 hours, and continue monitoring once the patient is discharged and dose dosing as indicated. Thank you for listening, and if you have any recommendations, please let me know. Thank you.